June 2021. Today we have Dr. James Ritter. He received his bachelor's degree in kinesiology and exercise science from Liberty University and his doctor of physical therapy degree from DeSales University. He completed his residency training at St. Luke's University Health Network's orthopedic physical therapy residency, where he served as chief resident. He is board certified in orthopedic physical therapy and also is a certified strength and conditioning specialist. So prior to becoming a physical therapist, he was a personal trainer, a certified exercise physiologist, and a track coach for 5 years, where he developed a strong foundation for loading clients appropriately. He's facility director at physical therapy at St. Luke's West End Medical Center, and he's adjunct faculty at DeSales University, where he assists in teaching therapeutic exercise and loading strategies. So without further ado, I will turn it over to Dr. Ritter. Just remember to make sure you A, log in, and then B, ask questions when you have them, either through the chat or over voice. And make sure you complete the quiz and the questionnaire or the course evaluation in my e-learning. All right.
All right, well, thank you, Steve. Appreciate it. All right, so as Steve kind of mentioned, we're going to talk a little bit about today's topic, which is, are we loading our patients enough? So here's some of the information that we need to go over from the hospital system. I think you've probably seen these in the previous grand round, so we'll go through them relatively quickly here. Here's the designation statement. Some disclosures. Unfortunately, I am not receiving any money for this, nor do I receive any money outside of my normal work job here. If anyone would like to change that, by all means, please shoot me an email, and we'll certainly do whatever we can there. All right, so to get into the topic at hand, and I feel like anytime we bring up lifting, we have to make some sort of kind of "do you even lift, bro" joke. But so I figured I'd throw in the little kid here, which is kind of cute. So our learning objectives today, we're looking at essentially some loading terminology, knowing the difference between strength, hypertrophy, and endurance, and then also having an idea of how to appropriately load patients. So the first thing we kind of wanted to talk about a little bit, and this first right here with exercise is medicine. Certainly, I realize that physical therapy is much more than just exercise, and in fact, sometimes it kind of is disappointing when people view us as just being exercise individuals. However, it is a significant part of what we do. And so it was about 2007 when the ACSM and a few other organizations came together to try to create this movement where essentially exercise started to be called medicine. And from that standpoint, I kind of ask if, as a profession, have we truly bought into that concept? Do we really believe that exercise is medicine? If we do actually believe that, then certainly we would not prescribe exercise willy-nilly. We need to have a reason and a rationale for why we're giving not only the exercise but the amount of exercises as well. So, I mean, we would be upset with a physician who gave us, some type of medication and didn't really think about the dosage. So likewise, we certainly should not do that with exercise. We want to make sure that we're in the right range. So this question, I'm not going to delve in too much. It's more just kind of a thinking point here. Are physical therapists the exercise experts? It's a little bit of a loaded question because there's a lot of people out there who kind of want to lay claim to that. And again, I'm not going to get into that necessarily today, but at the very least, I think we should ask ourselves, if we view ourselves in that particular stance, then we should know why we're prescribing the exercises we're doing in essentially all instances. And once again, making sure we're not doing those willy-nilly. I did want to bring up some COVID considerations because we can't get away from that these days. From that standpoint, the JOSPT did come out with an article recently talking about how with patients who have had COVID, we may need to be a little bit easier on them than necessarily would in a population who has not had COVID. So the things that we talk about later, in this article, were the research was done before COVID and not with COVID-specific patients. So please keep that in mind when you do see the COVID patients. All right, there we go. So the first thing we're going to look at here is what is load, and load essentially is the combination of intensity, volume, rest intervals, and frequency. So intensity, simply defined as, if you're lifting weights, it's the amount of resistance that you're doing, or if you're running, it's how fast are you running. Volume is kind of the amount of work performed, which essentially would be sets times repetitions. And if you're running, that's really more of just the total distance. Rest intervals is kind of self-explanatory when you're not doing those particular activities. And we will talk a little bit briefly today about the appropriate amount of rest intervals in between sets. And then frequency is essentially how often you're doing those things. So load altogether is essentially those things combined. So it's essentially the combination of volume, intensity, sets, and reps. And so that's something we do want to kind of keep in mind as we're moving forward. And we'll go into a little bit of the research later to see what's more valuable or what's more beneficial to increase, whether it's intensity or volume, because increasing one of those variables will increase the total load, obviously. And then at the bottom of the slide here, we have homeostasis plus load equals adaptation. That's nothing new and nothing, surprising to us. We know that, we're usually at homeostasis. You need some type of loading or some type of stress to create adaptation. And we want to make sure that our loading is enough of a load to make sure that adaptation is actually occurring. All right, so some of the loading benefits, we'll go over this relatively quickly, because we are kind of all pretty familiar with these already. So mechanical loading, so we can have muscle and bone hypertrophy. We're going to go very briefly into cartilage. Today we're going to be focusing predominantly on muscles, but we'll talk briefly here about cartilage. So appropriate loading does actually help increase cartilage to regrow. This does it by inhibiting pro-inflammatory chemicals, facilitating increases in joint synovial fluid, and then we also end up with anabolic chemicals as well. Loading in general helps to facilitate pain reduction, which is kind of really pretty cool. Has anti-catabolic and pro-anabolic effects. There's actually a study in 2016 by Daniel J. Long et al. So they essentially created this term, or started using the term mechotransduction. We're going to go into a little bit of what that means in the next slide here. But essentially, what a lot of their study was looking at was, by using this concept of essentially loading, could we decrease the amount that cartilage actually degrades over time? A lot of times, we hear about, particularly in the news, hey, if you load your cartilage too often, it degrades. Well, if you don't load it enough, or at least to the enough amount, then that actually causes that degradation as well. So we want to make sure that we're keeping an eye on that. This study in particular found that at least 20 minutes of weekly rigorous physical exercise, and to be specific, that was defined as activities that lead to shortness of breath or sweating. So that's one of the things that we want to make sure, and we're going to go into that in a little bit as well, making sure that the intensity, or making sure that the effect is high enough to get what we're trying to get. So the mechanotransduction that we're talking about, so essentially what ends up happening, individual cells sense and respond to the loading. It's pretty much just the adaptation that we were talking about. Those cells were found to communicate across the application of forces and membranes to nearby cells, which is actually kind of cool, because you can actually have a positive impact on cells that you aren't directly loading, on the cells that are kind of in the area as well, which I think is really pretty cool and helpful for us. And then the neighboring cells respond by remolding the cellular matrix, which is kind of helpful. And again, it kind of grabs not just the cells that we put the force through or the load through, but the cells around the area as well. This next slide, we're looking at a picture that looks kind of complicated at first. And so we're going to go through it relatively quickly. I'm not going to bog us down with all the different type of responses here, but essentially the important component for us is that from a cartilage standpoint, we need to load about 50% of your effort. So essentially what that means is 50% of your 1 rep max. That doesn't mean that you have to sit there and you have to figure out what a true 1 rep max for each joint and for each muscle group is. For those of you who are familiar with how to do that, the NSCA kind of breaks it down very specifically. That process takes way too long for what we have in our options. So, but rather the 50% is 50% effort. So they found that as long as the patient is doing 50% effort, or considered moderate loading, you're going to end up with cartilage that actually ends up helping to be remodeled. And later, we're going to talk more about how to ensure a patient is at 50% effort, and we'll go and probably a little bit higher, than 50% as well. But we found that it needs to at least occur to get that loading for cartilage. I do want to point out that I'm not talking about, day one, meniscus repair. I'm not saying that we should be loading them 50% effort. Certainly not. Tissue healing still comes into play. But this study found that if we get patients to load their cartilage on a regular basis of 50% effort, that actually decreases the likelihood of degradation long term. And where I think that really matters for us, and kind of going back to that exercise as medicine component, we have the opportunity to kind of have an impact on our patients, their culture, the way they look at exercise, and the way they move forward to hopefully help them avoid those cartilage issues, knee OA, etc., down the line. All right, so let's get into a little bit of the terminology. I'm hoping that most of this terminology is review. But I do know that not everyone necessarily has a kinesiology background or a strengthening background from undergraduate. And in our case, we don't necessarily always use this terminology as often as maybe we should. So we'll kind of go through these and explain that a little bit. So specificity, you're probably pretty familiar with that. It's training adaptations for an individual will occur specifically to the muscle groups trained, the intensity of the exercise, the metabolic demands of the exercise, and specific movements and activities. So basically, a little more simply put, if you're a sprinter, and if you want to get your patient back to sprinting, you're going to want them to sprint. You don't necessarily want them to do, 5-mile jogs, things like that. If a patient wants to work on gardening, then we need to work on gardening movements, getting up and down off the ground, not necessarily, along our quads isn't necessarily going to do a ton for them, at least from a specificity standpoint. From the individuality, that's actually something that I think is important for us to keep in mind as PTs, because I think sometimes, at least for me, I'm not going to speak for anyone else, but at least for myself, it's easy sometimes, particularly if you're in a rush, to have a patient with a similar injury or a similar history as someone else, and you end up giving them similar exercises and similar loading. However, from that standpoint, we need to keep in mind that everybody responds differently, even to the same exercises, to the same stimuli. One of the biggest things in the research that they found that really comes into play here is also the person's previous history with injuries and previous history of weightlifting, previous history of exercise. Steve certainly is a big proponent of realizing and knowing, a patient's background. But that's a huge component that we may actually need to change our loading just based on their previous experiences. All right, so the next one here, looking at overload. So again, this isn't anything that should be new to us. In order for an individual to achieve a certain training adaptation, the body has to be stressed, plain and simple. It needs a stimulus or a load that is greater than what it's currently accustomed to. Overload ensures improvement by challenging changes in resistance, and that could be, changes in terrain. That can be changes in movement complexity. It doesn't only have to be resistance. There's a couple different ways that we can kind of play with that. Okay, so we're going to keep coming down here. So then, from a progression standpoint. One of the other components that we want to consider certainly is to progress our patients. And in order to achieve the desired training adaptations for an activity, we have to continuously be moving forward. So from an adaptation standpoint, if we increase a patient's homeostasis or increase the load, then essentially the patient will create a new homeostasis where the body adapts to that situation. If we continue to utilize the same exercise or the same load that we used to get to that point, we're going to actually see a little bit of a decrease as opposed to a continuous increase. So we have to continuously be progressing our patients, and we're going to go later into the appropriate way to do that. Excuse me. From a diminishing returns standpoint, and this is something that I think is great for us as providers, and it's great for us when we're working with our patients. A lot of times we actually are able to get pretty good return on investment or pretty good results in a pretty quick manner. This is particularly for patients who are undertrained or deconditioned, simply because they're starting at a lower point. It's much easier to move that lower point higher than it is for someone who is already, in the upper echelon and trying to get them even better. It's just more challenging. So while I know for many of us from the provider standpoint, it is sometimes frustrating when patients don't understand the terminology or don't have some of the experience we might expect them to. It actually gives us a pretty nice advantage and a pretty nice opportunity to have a pretty big impact. So from my standpoint, at least, I tend to have to back myself up and say, okay, hey, here's an opportunity, not here's a problem. I also want to keep in mind from the diminishing return standpoint, a lot of times around the 6 to 8 week, the research shows that that's roughly when we're going to start to see some of those diminishing returns. And so from that standpoint, please keep that in mind just when you're creating your programs and creating your periodization, and say, hey, around that standpoint, let's make sure we're changing it. Not only just increasing resistance or something along those lines, but even just an entirely different exercise, kind of switching things up and making sure that we're taking the most advantage that we can. Reversibility. I think this is incredibly important. The APTA came out with a statement about wanting to optimize the human experience, and certainly as providers and healthcare practitioners, we certainly want to do that. That's why we got into this in the first place. And part of the concern that I tend to have, and I think we've all have seen a patient like this, where we're able to progress them beyond where they are currently, they stop taking our advice, they stop, whether it's, you know, medications, whether it's the exercise we prescribe, whatever it may be, they stop performing those things, and then we see them back 2 years later for a similar problem. And so from that standpoint, that's literally reversibility, where we get their homeostasis to be at a higher standpoint, they stop utilizing the stimulus that got them there, and they literally just revert to where they were before. Now, certainly we helped that patient, but I would argue from a standpoint of, you know, could we have done more for that patient? How much of an optimization did we really create there if they just reversed to their previous level? All right, so kind of continuing with some of our terminology, these ones you might not be quite as familiar with. So macrocycles, mesocycles, and microcycles. For our standpoint, and I'll go through these ones a little bit more quickly than the last ones. For our standpoint, the macrocycles is essentially long periods of time. We're thinking 6 months to a year, that type of thing. Think about your patient who comes to you and says, hey, my granddaughter is getting married 6 months from now. I want to be able to walk down the aisle, you know, without a cane. I want to be, whatever that may be. And so essentially the goal or the achievement there is trying to be able to walk down the aisle without a cane, or maybe, you know, being able to dance, you know, a specific dance with them at their wedding, something along those lines. In that case, because we have that much time, we're creating essentially a macro cycle where in a sense, our competition is that point where they're going to do that activity, walking down the aisle or dancing. Mesocycles is more so what we deal with on a more of a regular basis. This is looking really more at that kind of intermediate. We're looking at like weeks, 4 weeks to a couple months kind of range. This is, you know, where we think about our goals, you know, patient will blah, 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 blah by 6 weeks, those type of things. And this is where we kind of essentially create a mesocycle, and in a sense, almost an episode of care arguably is a mesocycle, depending on the duration. And then a microcycle is a much smaller division of time. It can be a couple days to a couple of weeks, where that's really more, you know, if we're thinking about like a home exercise program. Okay, so one of our goals there is we want the patient to be able to do the home exercise program correctly, and that probably isn't an 8-week goal. That's more of like a few week goal. Now we're going to progress the HEP, hopefully. Excuse me, but you know, at least initially, that's going to be more of like a microcycle, a smaller period. It's kind of interesting, and what I kind of like from that standpoint is it actually shows that from the research standpoint that we only need about a week or two to start to see some adaptation. I didn't want to delve into the neuro component too much here because we could go down that rabbit hole, you know, on its own. But some of the research that I found suggests that the early adaptation really is more of a neuromuscular adaptation, neuromuscular control. The body becomes more efficient at recruiting motor units than necessarily true muscle hypertrophy or strength or endurance gains. I mean, and that certainly makes sense, but I think it's important for us to keep that in mind, particularly, you know, for the patients who get better very quickly, because if we do not get them to the tissue adaptation standpoint, they're certainly going to have reversibility pretty quickly. Oops. All right, so the general adaptation syndrome. So a lot of times in the literature, this is shortened to just GAS. This essentially has 3 main phases. It's the alarm phase, the resistance phase, and the exhaustion phase. Most of the exercise and conditioning, most of the muscle adaptation literature out there has some variation of this concept kind of in its core. So the beginning here, you'll see that dotted line across the screen there is essentially homeostasis, whereas the red line is the body's response to a stimuli, or, you know, in our case, loading. So what you're going to see is initially there's actually going to be a decrease where the body essentially kind of almost goes into not quite fight or flight, but an alarm type of phase where it's freaking out because it has a new stimulus it hasn't adapted to, it's not accustomed to that. And as you'll see, after the initial stimulus, it's kind of where the loop kind of comes to the bottom there. It starts to come back up. That's during the recovery phase. And the goal then is where the body remodels or adapts to have a new higher level of homeostasis. The exhaustion phase is essentially when we have not allowed, whether it's the patient, the athlete, you know, whoever we're utilizing this model with, we have not allowed them a proper amount of recovery. So they actually can potentially go into tissue death. That's certainly the extreme, you know, component, but this is again where I kind of bring up the concept of exercise as medicine and making sure that we are prescribing inside of therapeutic zones. If we have too much of a medication from a physician, that potentially can have negative side effects. Exercise can do the same thing. So it's something we definitely want to keep in mind. All right, so it seems we can't get past anything these days without going with the CDC guidelines. Please keep in mind the ACSM and the NSCA also have activity guidelines. I opted to use the CDC guidelines just because the CDC is pretty popular right now and people are a little more familiar with them. In general, I'm biased because of my background and my certifications. I like the ACSM and the NSCA, but just to kind of keep those guidelines in mind. The first two bullets here, that's an OR. So you can have 150 to 300 minutes of moderate. Again, that's 50% of max heart rate, or 75 to 150 minutes of intense, greater than 70% max heart rate. We need to combine that with plus 300 minutes of moderate tasks, so yard work, recreational activities, those type of things, and at least 2 days of resistance training. And I think that's something that often goes missed. I think certainly to the detriment of our society, and we'll get into a little bit more of that as well. All right, so strong people are harder to kill. So that's a little bit of a provocative thing to say, right? Let's call it what it is. So that's a quote from Mark Ritter. He's pretty well known in the strength and conditioning community, and he is a little bit of a provocative individual. But statements like that kind of help us remember. So we know from the research, and we've seen this hundreds of thousands of times. People who are stronger are essentially people who who exercise have less comorbidities. They have less hypertension, less diabetes, less type of chronic pain, those type of things. And we find that those individuals tend to live longer, tend to function at higher levels, and they are better able to adapt to stimuli that occur. A super easy example, think about our total knee replacement patients. The research shows definitively that the stronger a patient is going into it, the better range of motion they have going into it, the better they are going to be on the other side. And so essentially what Mark here is trying to get us to consider is that from a population standpoint, if we want to have a stronger society, if we want to have a stronger people, we need to make them stronger. We need to make patients push themselves. We need to enable them to overcome some of these issues. Particularly from a chronic standpoint, there's been so much research about chronic pain and becoming stronger, and how becoming stronger helps chronic pain. And that not only impacts, their physical health, but also their mental health as well. And again, we're not going to dive into that because that's a whole nother rabbit hole, but that is something kind of to consider, that people who are physically stronger have been found to be essentially stronger, having higher quality of life in multiple areas. Now, this chart itself, I hope that you're familiar with this chart. I know that a lot of people are not, which is why I brought it up. And to me, it's one of the most important things that I feel like I got from all of undergraduate. This chart breaks down your repetitions and what you're getting out of your repetitions. And so what I mean by that is, so when we're having patients performing their exercises, and keep in mind, in this case, the research shows that 3 to 5 sets is really kind of the best place you want to be. And so this chart is assuming that you're performing 3 to 5 sets. So if we look over here, kind of the top left, we see strength and power, and how those repetitions are really pretty low. We're talking, like 4 repetitions, 3 repetitions. 6 is kind of the upper component there, where we're starting to get away from power a little bit. But the reason I bring this up is because if we think about that patient who we're trying to help them perform a sit to stand, something that seems really pretty simple, but for a lot of people is really pretty challenging. That technically is a power and strength movement for that particular patient. And so if we have that patient on leg press, where we're doing, let's say the patient's 180 pounds, and we're doing 3 sets of 75 pounds on leg press, and they're doing 15 repetitions, if we look at this chart, and if that repetition is truly their max effort for those 3 sets, we're looking really more muscle endurance. So is that really going to help the patient perform one sit to stand? Honestly, probably not. I mean, you'll see from the chart there is some hypertrophy there. There is some, gains in regards to strength and power there, but it's really pretty small compared to what we could be doing. So perhaps for our patients, what would actually serve them better is having them on leg press, performing their max resistance. Let's say that's, maybe 120 pounds for this patient at 4 repetitions, doing 3 sets of that. It seems kind of strange that 4 repetitions is not something that we necessarily think of a lot when it comes to therapeutic exercise. But if our goal truly is to increase strength and power for that sit to stand, then that is actually where we need to start. Then once that patient is able to do that, now we start to use those terminologies and those concepts that we talked about earlier. Okay, now we're going to avoid diminishing returns by we're going to increase the repetitions. We're going to change the stimulus from that standpoint. But that's just something to kind of keep in mind. And that's something that as a student, I saw pretty often, if we're going to be honest, in some of my rotations, certainly not in the rotations I had here, but in the rotations that I had in some other networks, was really disappointing. And 6 weeks go by, and hey, the patient still really can't do more than half of a sit to stand. Well, because we're not loading that patient for that activity. And so this is a chart that if you're not familiar with it, I highly recommend stealing it from this presentation, and kind of keep it in the back of your mind, because this is in some ways really the core of a lot of what we're doing, what we're talking about today. So let's dive into the research a little bit, because we kind of talked about kind of some ideas of how we know what area we're working on, whether it's endurance, hypertrophy, strength. But the question we haven't really answered yet, though, is how much loading do we need to have, right? So we talked about 50% for cartilage, and really for muscular gains, we're looking at least 60% of 1 rep max. Now, please keep in mind, kind of like I mentioned a little bit earlier, 1 rep max in this case does not truly mean that we need to sit there. We need to figure out, okay, this patient's bench press is 100 for the 1 rep max. That's not realistic and not always appropriate. In this case, 1 rep max really is more referring to total effort. So 60% of their total effort. If the exercise that we give our patient is less than 60% of their possible effort, they're really not going to see much of a response, not much of an adaptation for that exercise, at least according to the research. So from that standpoint, we kind of are wasting our time, we're wasting the patient's time if we give them anything that's less than that. Now, again, I'm not saying that tissue healing doesn't matter. Tissue healing does matter, but I'm just talking about purely from an effort standpoint at this moment. And from our standpoint, we need to put tissue healing into consideration. We need to put as the patient post-surgical, those type of things. But just for the sake of brevity, in this case, we're kind of focusing on what we need to happen for the adaptation. And so one of the components here is, and to kind of keep in mind, is that if the exercise is under 60% of your max effort, your gains are going to be pretty paltry. So if we give an exercise to a patient, let's say 3 sets of 10, which is kind of the hallmark, right, of physical therapy, everyone kind of thinks 3 sets of 10. Makes me a little sad inside, but that is kind of a lot of times what we end up doing. If that patient rocks out all 3 sets right in a row and ends up doing 30 repetitions without needing a break, clearly we were nowhere near their 60% effort. And I think we can all say we've seen at some point, whether we were students and we saw it, or whether, maybe sometimes it happens to us. I'll be honest, it's happened to me once or twice, where I'm like, oh, you know what, I clearly wasn't challenging that patient with that exercise enough, and it ends up not really being as beneficial. Now, speaking of being beneficial, and I mentioned earlier that we would talk about this, this study looked at not only essentially the results, or how much effort needs to be put forth, but also which variable is more valuable to change, volume or intensity. And without any question, it was found that intensity was the most valuable variable to increase. So they actually had two different groups, roughly about 45 patients each, or subjects, I should say, in this case. And they found that the group that the increased intensity had vastly superior improvements than the volume group. Now, keep in mind that when we change volume and intensity, we can still end up with this same total load. And so they actually had both of these groups have a similar amount of load. So even with a similar amount of load, having increased intensity, which, if we remember, essentially is the resistance, or in running, the running speed. So when we're trying to get those adaptations, when we're trying to get increased muscle hypertrophy, when we're trying to get decreases in pain, which is partially what this study was looking at, they found that increasing the intensity was more valuable. And that's something that I think from a physical therapy standpoint, we can certainly, and really just from a provider standpoint, we can kind of consider with our exercise prescription. We need to increase the intensity of our patients to get to the goals that we want. And again, and I know a lot of times, and I think there's a little bit of a stigma, and I kind of want to get into this and now a little bit. I think there's a little bit of a stigma, and it makes me kind of sad inside that our patients who have more experience in life cannot lift heavy. There's almost like a concept that lifting heavy is disadvantageous for patients with advanced age. And I want to challenge that a little bit on a couple reasons. One, because the research shows that that's not necessarily the case. And certainly, in terms of osteoporosis, we need to be careful, but osteoporosis has actually been found by the research that we need to load it to kind of help combat that. And so, yes, the lifting heavy for a geriatric patient may be a little bit different than a 21-year-old athlete, certainly, but the amount of effort put forth is still going to be relative. It's still going to be relative to that individual. An easy example that I'd like to kind of throw out there was my dad. So my dad had a heart attack a couple years ago. He was out of shape, had a pretty bad lifestyle. I tried to, telling him, tried warning him, but, working with family members is not always the easiest. And so he ended up having a heart attack, recovered really well. In fact, to the point to where he was working out so hard and so consistently that he actually was stronger and in better shape in his 60s than he was in his late 20s. So he was actually stronger in his 60s after his heart attack than I had ever seen him in my entire life, because I was born after that point. So in that case, yes, 60s is not necessarily geriatric. We're kind of getting to that point. But regardless of the age standpoint, we still have an opportunity to see patients have impressive gains and impressive improvements. And I kind of bring that up a little bit because I think it's important for us to keep in mind that when a patient comes sees us, they're at a stage where they recognize something is wrong and they're potentially more ready or more willing to have some type of change than they were, let's say, 3 years ago. Again, in the example of my dad, he needed a wake-up call. Unfortunately, a heart attack is a little bit of a rough wake-up call, but sometimes we can utilize this as a wake-up call for our patients. All right, so we talked about now that we want to be at 60% effort, and this, which is great and helpful from a prescription standpoint, but the question still kind of becomes, how do we really know that we're at 60% effort? So this study that was done in 2019 was essentially looking at Paralympic swimmers, so relatively highly trained individuals, and essentially trying to figure out, okay, are they aware of how much effort that they have left? So essentially the idea was they took 30 training sessions and they would have them do multiple laps. And they would say, okay, hey, how hard do you think you're working right now? And they would respond on the RPE scale. So the RPE scale, for those of you who may not be familiar, is 0 to 10. The lower on the scale, the easier you're working. So like a 0 is, I'm not working at all, I'm kind of sitting resting. 10 is, oh my goodness, I'm about to pass out. This is as hard as I can possibly work. You may be familiar, there also is a 6 to 20 scale. I prefer the 6 to 20 scale because that scale is supposed to go with heart rate. So if a patient says, hey, I'm at a 10 out of the 6 to 20, that means their heart rate is roughly at around 100. The research shows, though, that the 0 to 10 scale is more accurate and patients understand that better, which to me is a little disappointing because I like the 6 to 20 better. But from a research standpoint, use the 0 to 10 because it's more effective. So they would ask the subjects in this case their RPE scale, and if they said, okay, hey, I think I'm at 80% of my max effort, I think I can do 4 more laps, let's say. And so then they would go ahead and they would essentially try to do the 4 more laps. They would also take their heart rate to see, okay, how close were they? And they actually found that there was a high correlation up to 0.8 for the RPE and the heart rate. So essentially saying that these individuals were actually doing a pretty good job of being able to say they're roughly in that zone. So from that standpoint, when we're working with patients, when we're advising patients, we can actually ask them, how hard do you think you're working? And they're going to be relatively accurate. Another thing that I actually found was really interesting about this study was that they also asked the coaches. They said to the coaches, how hard do you think this swimmer is working right now? And the coaches essentially created an RPE for the performer. This part probably isn't too surprising. The coaches were pretty far off. They were not statistically significant for being correct on heart rate. And they actually were also found to be statistically significant for being different than the athlete's perception. So that also kind of, I think, is important for us to keep in mind that when we're observing a patient, when we're working with a patient, let's make sure that we're asking them, how hard are you working? Not just assuming that, because at least in the research that I kind of found from this standpoint, we might not necessarily be quite as good at assuming how hard they're working, at least as I would have assumed that we were. That study does bring up an interesting question, though, because in that case, they were pretty well trained. So this study here, which talks about determining intensity, did a couple of things for us. One, it's looking at the accuracy in estimating repetitions to failure. And so essentially what that means, and a lot of times that's kind of abbreviated RIR, or autoregulation. The concept there is, how many repetitions do you have in the tank? So the idea there is, let's say I have Dr. Karaha doing some hang cleans, and he's doing, I don't know, let's say 3 sets of 10 at 50 pounds, let's say. And I say, okay, Steve, on this very last set, do as many for me as you possibly can. Don't just, don't try to do 10, try to do, 20, 30, whatever. And if we find that that particular individual is able to do an extra 20 or so repetitions, clearly they had a lot left in the tank. So we know that we were not loading them or putting them up to their effort as much as we should have been. And so this study is looking at that concept and trying to say, hey, are patients able to look at the exercise they're doing, and are they able to estimate how many more repetitions they have left in the tank? Are they able to notice that? So this group had 53 men, 28 women. They performed up to 10 sets of 10 repetitions at 70% effort for chest press and then 80% effort for leg press. And the study found that if the patients only had 0 to 5 repetitions left in the tank, they were able to estimate that within 1 repetition. So really pretty good there. If they had more left in the tank, if they had 6 to 10 repetitions left in the tank, now we started getting a little bit larger margin of error where they were at least 2 repetitions off. So from that standpoint, that's something to kind of keep in mind, that in general, according to the study here, and one thing I did not mention that's very important for the study, which is one of the reasons why I added it, was that in this case, they looked at trained and untrained individuals to see if there was a difference. My expectation would have been that trained individuals know their body better and are better able to estimate how many repetitions they had left in the tank. However, according to this study, there was no statistical significance between the trained and the untrained. And I think that's important for us from a rehab standpoint, because like we mentioned earlier, many of our patients are untrained. And so despite that fact, they actually still are going to be able to do a pretty good job, assuming that they only have 0 to 5 reps left. If it's more than that, okay, then the validity of it starts to decrease a little bit. The study also found that the statistics were slightly better for chest press. Patients are more able, the assumption there is that patients are better able to tell for their upper body than they are for their lower body in regards to how many repetitions they have left. There really was not much of a difference between men and women in that particular case. For chest press, they were pretty much dead on from the statistics between men and women. For leg press, women were a little further off of how many that they had left in the tank, but for the most part, there wasn't a massive difference there. And so we want to look at this next chart here, where it kind of talks about those 2 concepts we just looked about, the perceived exertion rates as well as the repetitions in reserve. I like this chart a lot because it kind of breaks down, okay, hey, here's where the patient says, if we look at the RPE on the left side of the scale here, okay, we're at 60%, which is where we want all of our patients to be, and they're working somewhat hard. If we look over at how many repetitions we have left in the tank, if they're at least 60%, that means that they cannot do more than 4 to 6 repetitions more of the exercise that we gave them. I think if I'm going to be entirely honest, this is something that I cannot say I always do a good enough job with all of my patients. Looking at it from a standpoint of, hey, am I ensuring that they literally, when they're done with their 3rd set or 4th set or whatever we're doing, can they literally not do 4 to more 6 repetitions? And that's something that I would argue that we can do pretty easily every couple sessions with our exercises. Hey, on this last set, give me all you got, and let's see what you have. If they're able to perform 10, well, then we clearly have not taken them to that 60%. We need to increase that to make sure that our dosage is appropriate. This chart is breaking down a study that was done in regards to running. So running versus walking. So walking has become, I would argue, a more and more popular kind of activity, and because there are a lot of health benefits from it when compared to doing nothing. And certainly, walking is awesome when doing nothing, but this chart breaks down the benefits of running versus walking. And if you see here kind of on the left-hand side of this chart, the study found that if we were to run 25 minutes a day, we would have to walk 105 minutes to attempt to hit kind of that same beneficial threshold. And if you see the bar here for the walking component, it actually tapers off pretty hard. And they found that after the 105-minute standpoint, there really is not much of an advantage past that mark. So basically, this is kind of going back to that concept we mentioned earlier, that higher intensity exercises tends to yield more favorable effects on mortality rates, on disease, lowering risk factors, etc. And so this again goes back to kind of what Mark Rippetoe mentioned about, hey, stronger people are harder to kill. And if we look at, again, this chart here, we see that the higher intensity exercises, and even for a shorter period of time, is going to have a much better impact from comorbidities. So this is also something that I think is helpful for us, because one of the big arguments that we get from patients, or one of the big kickbacks, is I don't have enough time. Well, if we work you in an appropriate difficulty, if we have the appropriate intensity, you won't have to work a ton. We don't need you to go do 2 hours of this. We need you to do about 20 minutes of this. And that's, going to put them in the area where they need to be. All right, so a couple components here, and this gets a little interesting. So basically, the concept here is minimum effective volume. So what is the minimum amount of loading that we need, that we can have for a patient to essentially have an impact? And yes, on one hand, the research is saying 60%. Certainly, but on the other hand, we also have to keep the concept of individuality in the back of our minds. So this concept is actually taken from Mike Israelette. He's a PhD in sports psychology. He's a strength and conditioning coach as well over at East Tennessee State. He actually came up with this concept, which I think is really pretty cool and relatively easily utilized. So essentially, what he does is to try to figure out the minimum effective volume. So the question that we can essentially ask the patients: Did you get the load give you a muscle pump? And I put BFR here in parentheses. There's a very good grand rounds on BFR. I highly recommend, if you're interested in the muscle pump component, to go listen to that one. They do a phenomenal job of breaking down muscle pump, going through some of the chemicals, etc. So I figured I wouldn't rehash all of that today for time, and also because, again, they did an excellent job there. So I suggest going back and listening to that. You also get asked, did the load make your muscles feel like they were challenged? So this kind of deals with, the rest of the day, were you a little stiff for a little bit, or do you feel like the activity was pretty easy? And then finally, did the load make you feel sore? And so each one of those questions are based on 2 points. So for example, did the session give you a pump? If it gave you no pump at all, that's 0 points. If you got a small pump, okay, that's 1. And if you got a great pump, so you had a significant amount of effort there, that's 2 points. Each one of those areas is based on kind of 2 points here. So for, did the session make you feel challenged? If you feel like your muscles were barely worked, that's 0 points. If your muscles had plenty of tension and they got pretty fatigued, that's 1 point. And then for the rest of the day, if your muscles felt stressed and like you could not do other activities for the rest of the day, that's 2 points. From a soreness standpoint, and this goes into this, and this is incredibly important for us as practitioners and providers, to educate our patients on the difference between pain and soreness. Right. And so soreness essentially, in most cases, means, hey, your body's being pushed, it's being forced to adapt. That's different than pain. Not everyone is used to that. Not everyone is used to being sore. So we need to make sure that we educate our patients beforehand. If you tell a patient after they're sore, oh yeah, I expected that, they're not going to believe you and buy into that so much. If you tell them ahead of time, hey, this might make you sore, this is what it looks like, this is what it feels like, this is what you're going to experience, then they're going to trust you more, because they're going to be like, oh yeah, you said this might happen, and they completely understand. So from the soreness standpoint, if you didn't get sore at all, that's 0 points. If you got stiff for a few hours, that's 1 point. And if you got sore for a couple of days, that's 2 points. So you add up those areas with a total possible score of 6. As long as you're in roughly about 4, then from Mike's research, he's found that that's roughly where you want to be. If you're at 5 or 6, we're probably pushing you too much. If we're at 3, well, really 2 or less, 3 gets a little borderline, but 2 or less, we're probably not going to see much of an impact. So that's also another subjective way to kind of get the minimum effective volume from our patients. So the other question, of course, is, maximal adaptive volume. And essentially, and this is something that I'm not going to go into every single point here, because I think this one you're all probably pretty familiar with. You might not be familiar with the terminology for it, but I think you're pretty familiar with the concept. So when a patient comes in and they're pretty sore, okay, let's say we had them doing lunges or squats or something along those lines. And they're pretty sore for a couple of days, and we have them on the bike and as a warm up. So normally what you want to see happen is you want to see, as they warm up, the soreness decreases, the joints kind of loosen up, they feel a little bit better. Okay, now when they're done, they're not really sore anymore. If we have them on the bike and they're going for a few minutes and, hey, that soreness has stayed pretty much the same, okay, we've probably gotten to that maximal adaptive volume and potentially maybe even pushed past it a little bit. We should probably decrease the amount of loading that we have. If the patient's there and they're sore and after warm-up the soreness goes away, perfect. Let's do that same exact loading again, because the body is adapting and hasn't entirely adapted yet. If the patient comes in, they're not sore at all, and they were like, yeah, I could barely tell that I worked out last time I was here. Okay, we're clearly under that threshold. We need to increase what we're doing and how we're loading them. All right, so this concept then is kind of a similar idea. This is the maximal recoverable volume. Basically, it's the highest load possible while still being able to recover to baseline. One of the easy ways that we can see this in our patients is, let's say the last session we gave them a load of intensity of 60%, and they were able to complete all of the repetitions. The next time they come into the clinic, and now they're having a hard time obtaining the same level of load and the same level of form during that load that they were the previous session. Okay, this suggests that they have not fully recovered yet. And this is also important to where we need to go into the subjective component with our patients. Is there some kind of external stress on them? Did they not sleep well? Because those factors can come into play as well. But if we find that the patient is not able to perform at the same level that they were previously, we probably have not allowed them enough recovery time. So from that standpoint, let's peel it back in the session a little bit. Let's make things a little bit easier. This may be good at opportunity for, even from an HEP standpoint, to say that the patient, hey, let's peel it back a little bit. Don't do your exercises for the next couple of days. And now that we're talking about the HEP standpoint, that's another component that I also want to bring up, because if we are pushing our patients to 60% or more of their maximal effort, from a weightlifting standpoint, we would not have patients, or we ourselves would not have us do that every single day. We know that our muscle groups need a break. So from an HEP standpoint, we need to keep in mind the amount of effort that our HEP is putting on the patient. If it's predominantly stretching or predominantly neuromuscular things where we're kind of more having them go through, proper range of motion, okay, fine. But if we're working them just as hard on an HEP every single day as they are in the clinic, we probably are not allowing them enough time to recover. And so we need to make sure that we are updating our HEPs. We need to make sure that we're adapting our HEPs as it goes, and keep that in mind with the total load, because not only are we loading them in the clinic, but we're loading them outside of the clinic as well. So checking for correct intensity. So a couple easy ways to do this. So last set to perform to a ramp, or as many reps as possible. If the patient is able to perform a whole lot more reps than we wanted in that set, okay, then clearly we're not having the correct intensity. The next point here, how close on the RPE scale or the RIR scale was the patient? So that's a really easy one. And I think, to me, this is also a really important one that I want to make sure that we understand, and also one that we try to make sure our patients understand. Because going back to the reversibility concept, if we send our patients out and they have not truly learned how to appropriately push themselves and how to get themselves to the correct intensity, they're going to revert. They're not going to be able to maintain the gains that we gave them. And then we haven't really helped them to the point that we certainly should. And I would argue that, particularly the A ramp should be performed every few visits to appropriately progress. So kind of making sure that we're always challenging our patients in an appropriate manner. And it's a relatively simple and easy way to do that. You certainly can take heart rate as well. That certainly is an excellent way to do it. I focused in on the RPE scale and the RIR scale, though, because one, it's easier to teach patients to do that for themselves. And two, it's easier for us to do that in the clinic. And then also, depending on the type of medications and things that patients have, that may actually change their heart rate or kind of stunt their heart rate a little bit. And so we need to keep that in mind as well. And so I brought up this chart again, simply because I like it as a review standpoint. I think that this chart and the previous chart that I mentioned with the strength, hypertrophy, endurance, and power, I think these two are incredibly important and give us kind of quick, easy visual reminders of how much to challenge our patients and to make sure we're trying to get the goals out of what we're doing. So in kind of summation here, intensity matters. We want to make sure that our patients are at 60% or more intensity. If we're looking at, if we're looking at increasing volume or intensity, the research shows that increasing intensity is a better way to go. RPE is pragmatic and reliable. RII is an effective barometer. We want to make sure that you know your goals, ensure your reps and effort are helping you towards your goals. We want to make sure that we challenge our patients and hopefully have an impact, a positive impact on the culture in general, because stronger people are harder to kill. And for those of you who are familiar with David Goggins, stay hard. So those of you who don't know him, he's a gentleman who became a Navy SEAL, and he currently does like a lot of motivational speaking, particularly in relation to exercise. I highly recommend checking him out. He's a pretty cool guy, and a lot of stuff is really pretty comical. he definitely knows how to push himself pretty hard. And then here are my references. Alrighty. Steve, did we have any questions from the chat?
Not yet. Does anybody have any questions? So thank you very much for your talk. So you mentioned one of the studies was looking at non-trained versus trained to see about the RPE. Is it just that one study that shows non-trained is pretty accurate, or are there other studies also, or are there any conflicting evidence in that area?
Yeah, so there are other studies that kind of confirm that. Just for the sake of brevity, I don't want to go into all of them because it's kind of roughly at the limit here. But there are multiple studies that show that. There was actually one study that showed that depending on the particular trained athlete, they are a little bit better. So if we're looking at specifically like power lifters, they're a little bit better. It wasn't a strong correlation. If I recall correctly, it was like a 0.6 correlation of being a little bit better. But for the most part, they actually found that there was really no, which again, kind of surprised me. I thought it would have been the exact opposite, to be honest with you. But
Hey, James, actually, thank you for your talk. I really appreciate it because I think we chronically underload our patients in the clinical setting. One thing I found, though, is that and just to kind of piggyback off of Steve with the ability of our patients to estimate their exertion, is that our elderly patients, like when we ask them, everything to them seems difficult. So I appreciate more like the reps in reserve or your RIR chart. But another thing that I kind of have, and I can share with you if you want, is a nice little chart, an estimation, a one rep estimation chart from NSCA. Where, you know, it kind of breaks down if the patient can do, or if your client or whoever you're training can do, you know, 3 reps of something at 15 pounds. So that's probably about, you know, their 1 rep max would be, let's just say for sake of, I'm not looking at the chart in front of me, but 20 pounds. And it would just like break down if they can do 3 reps at this weight, then they're probably at this percentage of their 1 rep max. And I've used that a couple times in the clinic, and I'm not sure if you're familiar with that or have any experience using something like that in your clinical setting.
definitely, yeah, I appreciate bringing that up. So in regard to the geriatric patients and kind of a lot of things being hard, that again is kind of where I was trying to get into the difference of, lifting heavy is relevant for them, right? And part of that is going to be keeping in mind what their homeostasis is, because their homeostasis oftentimes is relatively low. So I appreciate you bringing that up because you're absolutely right. And so lower level activities may still be pretty challenging for them. And definitely. So from the chart standpoint, and I know the one you're talking about, most of and it's a great chart. I've utilized it many times, particularly when I was coaching track, actually. Most of the research that I found, at least most of the more recent research in the 5-year kind of standpoint, was using more the RPE scale and the RII scale. So that's why I kind of went in that direction. But I agree. I mean, I think that chart's very valuable. And I mean, again, I'll be honest, I'm biased towards anything from the NSCA because I think a lot of their stuff is really pretty good. So yes. So thank you. I appreciate you bringing that up.
Yeah, and just like I said, my own clinical experience is some of our older patients, it's like one sit to stands and like, I can't do anymore. And it's like, well, I think you probably can, but.
Yeah, that's another great point. I didn't want to go into, the motivational interviewing and all that kind of component of it. And we could do an entirely another, easily another hour on the kind of sports psychology of that. So yeah, you're absolutely right. I couldn't agree more.
One of the questions that gets brought up is things like chronic fatigue syndrome, long hauler COVID, those pathologies or disorders that have significant repercussions for overload. A lot of times when things are prescribed, they are based off of the repetition maximum. But what do you think of? Do you think utilizing the perceived exertion would be safer and a better bet, or do you think it wouldn't really matter using one versus the other?
Yes, I mean, so I think the RPE is valuable there. I think anytime we're getting information back from the patient, I think it's valuable because it tells us a lot about the patient. And I apologize whoever had been talking previously, the name didn't come up. kind of like she was mentioning, that perception of the patient, having that is important just from that therapeutic alliance. And we know that the therapeutic alliance is incredibly important to kind of help our patients get better, which again is another rabbit hole I didn't want to get into. In regards to the repetitions in reserve, I've found that if I ask my patient to kind of give me all they have on that last set, they sometimes will surprise themselves on how much they're capable of doing. And again, you have to kind of know the patient, but I found even our geriatric patients, and even just me saying that is kind of terrible, saying even our geriatric patients, but our geriatric patients as well, because I think the expectations we put on them also has a big component. And so if the expectation is, okay, because you're more advanced in years, you're going to be weaker or capable of less, I think that starts to, people perceive themselves that way. And so I think it's important for us to perceive them as being able to do more. But from that standpoint, I think sometimes they can surprise themselves, and they get excited. They want to see that they make progress. They want to see that they can do more. I just had a geriatric patient recently who was talking, and what she was so proud about was she could do more than other people in her age group. Like, she was incredibly pumped about that. I mean, nobody wants to be weak. Nobody wants to be, everybody wants to be strong. And so I think from that standpoint, using the RIR, I think gives us a good advantage to show the patient what they're capable of. And so that's kind of a long-winded answer to that question, but that'd be my argument.
Thank you.
Thank you.
What other questions do you guys have?
All right.